Welcome to this evening's M&M event, Right Care, Right Time. We know that these are tough topics and often tough decisions. We are here to help you navigate this part of your journey. As a community of advocates here before you, we need to elevate these conversations on your care. We need to have open conversations with our family and help build language. We here at McLean honestly want to be a resource to our community of residents and families that we serve, as well as to the community at large. So again tonight, welcome. Tonight you will hear lots of information and it will keep you asking questions, and that's good. So tonight our panel includes McLean, who's our Director of Admissions for Post-Acute and Skilled Care. We have Jenny Braddock, who's the Director of Outpatient and Inpatient Rehab, and Peggy Coburn, who is our Administrator of Home Care and Hospice. So tonight we're here in our beautiful independent living Goodrich building, but just up the hill a little bit is our healthcare center. So in our healthcare center, we are able to offer assisted living, skilled nursing, post-acute, in and outpatient rehab, and home care and hospice. And these ladies will address all those topics in a few minutes. So my name is Ann Pavano, and I'm the Director of Assisted Living. Tonight I'm going to speak to levels of care, our day program, and support services. So AL, Assisted Living, offers a bridge of care that families are no longer able to provide. Care in AL will be consistent and 24-hour care. So what that means in terms of consistent care, we are very lucky to be fully staffed in our assisted living. So we have CNAs who are there 24/7. These CNAs are frontline workers for the people they care for. And consistent care in that if your loved one was on one of our neighborhoods, I could tell you that next Wednesday it's going to be one of 4 women, and those women combined probably have 40 years of experience and much of their time here with us at McLean. So we're very proud of that. We have a very consistent team of frontline workers. And again, we have 24-hour care. Our CNAs are 24 hours, 365 days of the year. Our nursing care consists of AL nurses who come in at 7:30 in the morning and are there till 8 o'clock at night. After 8 o'clock until 7:30 in the morning, we have nurse oversight in the healthcare facility. So speaking to our different levels in assisted living, we have 2 neighborhoods. We have the Robinson neighborhood, which is on the first floor of the health center. So this neighborhood consists of folks that are really the most independent of all the folks in our health center. And then upstairs we have our Atwater neighborhood. Our Atwater neighborhood is a secure neighborhood for those with cognitive impairment. It's important that it's a secure neighborhood because the reality is that 60% of people with cognitive impairment will wander. So it's important that it's a secure neighborhood. So if we're talking about the levels of care, on both Robinson and on the Atwater, our assisted living neighborhoods, we have 3 levels of care: core, supportive, and enhanced. These levels of care are determined by individual care needs and person-centered information. It's often talked about when we're talking about care for people in assisted living, you hear the words ADL, or the acronym ADL. That stands for Activities of Daily Living. This consists of bathing, toileting, dressing, medication management, and ambulation. Other factors in considering assisted living is socialization. So this is a big component. Socialization is important for well-being for all of us. So maybe your loved one, maybe your mom is in her home in the community, or maybe even here in an apartment in our independent living. But she no longer is able to have the ambulation, no longer has the energy to get out and about and socialize. When someone comes to assisted living, they have their apartment, and right outside their door, they have the opportunity to socialize with their neighbor or to participate in the life enrichment programming. Our life enrichment team in the health center provides this life enrichment programming, offering meaningful engagement programming. Another factor when considering assisted living is caregiver fatigue. So caregiver fatigue is real and statistically significant. Caregivers often feel like they've lost control of their lives. They feel overwhelmed, tired, sad, angry, irritated, and might have signs of depression. So just as your loved one is worthy of well-being, you as a caregiver are worthy of well-being too. So that's certainly a consideration when a loved one comes to assisted living. Another frequent motivation in coming to assisted living is an event. An incident might happen. Maybe mom has a fall, ends up in the hospital, and maybe ends up in our post-acute. The family might decide mom's no longer safe at home and needs to come over to assisted living. Maybe it was mom and dad living together in their home, and maybe a spouse passes away. That spouse was maybe the main caregiver for the other person. So now the rest of the family feels no longer mom is safe in her home alone. And that's another reason people often come to assisted living. In assisted living, you're able to age in place on the neighborhood that you enter into. But the advantage of being in our continuum of care or in the health center, we have options. People might, as their care needs increase, they might need to transition through the continuum of care that exists in our health center. Another fact is that we're very proud of is that we are a Purple Flag facility. What this means is that we offer best practices in dementia care. In fact, we are the first facility in the state and beyond to have this distinction. And the cornerstone of this is that our frontline workers have 12 hours of dementia education every year. Our ancillary staff, including dining and housekeeping, have a minimum of 4 hours of dementia education every year. But maybe your loved one with dementia is not ready for residential living. We're lucky enough to be able to offer a day program up at our health center. Our day program is offered 5 days a week from 9 to 3 o'clock. The gentleman who runs the program, Terry, he is a gift to that program. He says that this is his dream job and it shows every day. He offers important socialization and social engagement for the people who participate in the day program and much needed respite for that caregiver. Other resources that we offer to our community of cognitive impairment loved ones is we offer a community cafe. So that community cafe is offered in conjunction with the Alzheimer's Association. We do that once a month here, and we welcome people with dementia and their caregivers to come and enjoy social engagement with others who are on a similar journey. We also offer a caregiver support group for caregivers of people with dementia here. Again, offered once a month. It's a very well-attended program and very well-needed program. At this point, I'm going to turn the program over to Michaela, who again is the director of our Director of Admission for Skilled Nursing and Post-Acute.
Hi everyone, like Ann said, my name is Michaela. It's nice to be here this evening. So quickly, I'm going to start with long-term care. Long-term care, the big difference between assisted living is that long-term care has 24/7 medical care and supervision. So this is for patients who have chronic health conditions that need close monitoring, 24/7 monitoring of a nurse or a CNA. And common diagnoses that we find kind of precipitate long-term care is dementia, stroke with residual deficits, congestive heart failure, end-stage renal disease, ALS, uncontrolled diabetes with complications. Same with assisted living. To qualify for long-term care, you do have to have the loss of 2 activities of daily living, which again, can be bathing, dressing, toileting, or feeding. Let's see here. Staffing is a little bit more, how would you say it? Robust, yes. Staffing is more robust over in long-term care because our residents do need more support. Licensed nurses, CNAs, and we also have a wonderful therapy department right on site. The environment in long-term care is a clinical setting, but at McLean it really does feel like home. It's not very institutional feeling, which I think is very unique and special. And a lot of questions I get regarding long-term care is, what is the cost? How do we pay for it? There's a couple different things. Some people have really wonderful long-term care insurance policies that would cover long-term care. We also offer private pay options, and we are a Medicaid certified facility. If you are to outlive your funds, we are absolutely able to take you in a Medicaid bed. So when do you need it? If you have a loss of those two ADLs and you're requiring 24-hour skilled nursing care, it's probably more likely you're going to need long-term care versus assisted living. A lot of times it's an early onset Alzheimer's or dementia. We do have a secure unit for those who might be wandering in long-term care. And again, just monitoring for those chronic health conditions. We have a variety of rooms, both private and semi-private, to accommodate everyone's different needs. And again, the difference is in assisted living, it's more residential style, and in long-term care, it is a clinical setting. How to plan. Obviously, no one's goal is to move into a nursing home. Sometimes it is necessary for your care, the care of your loved one. My recommendation to everyone is, if you do have, or even if you don't, if you have medical conditions you are concerned about in the future, and you don't live here on campus, recommendation is to get in as many applications as you can. The state of Connecticut right now, we're kind of underbedded for nursing homes. So many facilities do have significant wait lists. The advantage of living here on campus is that you do get priority admission to long-term care should you need it. That may be a conversation between myself and Amy Daniels, our, what is your title, Amy?
Care consultant.
Yes, care coordinator. So her services are available, and she works directly with me to make sure that you're getting the appropriate level of care here on campus. And if you do need a transition from independent to assisted or to long-term care, we'll be there to support you and guide you through. And I think that's about it. Are we going to talk about? Oh, post-acute. So short-term rehab also. We offer that. It's a 14-bed unit here at McLean. Most patients come to post-acute care after an event, a hospital event, whether that's a stroke, you fall and break a hip, a knee replacement. Any of those do qualify you to come to rehab. Now, I do like to mention that if you are a traditional Medicare holder and you are in the hospital, it is important to know that you need a 3-night inpatient overnight stay at the hospital. So it's important to ask because sometimes they'll tell you, oh, you're being admitted and it's only to observation. So you could spend 4 or 5 nights in the hospital in observation and Medicare will not pay for it because you were not put on inpatient status. So it's really important to advocate for yourself and make sure you're admitted to the correct level of care. Because unfortunately, when they come to discharge you, you'll find out that no, Medicare is not going to pay for any post-acute care. And then it becomes more of a crisis situation trying to figure out, is it an out-of-pocket expense or do you have to go home with less support? So that's something I really like to mention often and just keep that in the front of everyone's mind. Now, if you have a managed care insurance, whether that's Aetna, United Healthcare, Connecticut, any managed care, you will need an authorization from that insurance company prior to coming to post-acute, either at McLean or at any other facility. It can take a couple of days sometimes to get authorization, so I do like to tell people to keep that in mind. If you're looking for rehab, talk to that case manager at the hospital, make sure they're starting that as soon as possible.
Thank you, Michaela. Hi, everybody. Again, my name is Jen Braddock. I'm the Director of Rehab here at McLean and a physical therapist by trade, but I do have the privilege of overseeing our therapy lines in inpatient, outpatient, and home care and hospice. So I'd like to thank you for taking the time out of your schedules to come and join us, and certainly we welcome any questions as we present our information, because I'm sure there might be a lot of questions that come up. So many of you, I'm sure, have heard of a physical therapy, occupational therapy, and speech therapy. But just kind of a quick overview, because sometimes people do get confused, especially between physical and occupational therapy. Physical therapists focus more on the gross motor skills, right? So range of motion, balance, strengthening, flexibility, posture. Occupational therapists are trained and focus more on those ADLs, what Ann was talking about, activities of daily living, dressing, bathing, toileting, eating, as well as fine motor tasks. And then speech therapists, kind of in the name, but they actually do a lot more than just working on your speech and your communication if somebody's having a hard time articulating and or understanding. But they also work on swallowing, right? So if anybody's having some swallowing difficulties, they can make some recommendations on best diets as well as compensatory strategies, as well as working on cognitive communication skills. So wide variety of services that we offer. Just kind of taking almost, an example of a transition, what Michaela was talking about. If somebody has that post-acute type of inpatient stay, they may need to come to, if they have an acute care stay, they may need to come to post-acute. And what that offers is a more intensive rehab experience. So somebody qualifies for that because they can't safely go home, right? The goal of everybody is to make sure that you have a safe transition home and that you don't have another rehospitalization, because no one wants that. So when you go into a post-acute setting, you have therapy typically 5 to 6 days a week. From there, we get you to the point where you might not be 100%, but safe transition home. And then Peggy's going to talk a little bit about home care and what that entails. But nursing, PTs, OTs, speech therapists, aides, social workers can then go to your house and help you in that transitional process in your home and looking at personalized more of that home environment and what barriers you individually have to face and how can we, again, come up with the safest possible outcome and best possible outcome. And then we have outpatient therapy. So on our campus, it is mostly an outpatient physical therapy clinic that we offer, not only to our campus residents, but also to the community at large. Uniquely for our campus residents, we can offer occupational therapy as well if needed, but we do not extend that out to the community because we just don't have the staff for that. But the outpatient therapists there, again, actually, we're very fortunate in all of our service lines. Again, like Ann was saying, from nursing to the CNAs to the therapists, there's longevity here, which tells us that we feel, I know the four of us feel that we're dedicated to McLean, that we believe in the mission and what we offer, and I think our staff does too. I mean, I have therapists that have been on staff for more than 30 years, 40 years. They're very experienced in treating a wide variety of ailments or injuries, anything from joint replacements, fractures, to neurological deficits, balance issues, vertigo, all those kinds of things. We also are very fortunate to have 2 occupational therapists that are trained in a driving assessment program that we have. This is very unique and not many places in the state of Connecticut even offer it. So what that is the insurance does not cover it. But if you or a loved one recognize that driving's getting a little tough, there's some safety concerns, the occupational therapist does a clinical assessment, very thorough, 90-minute clinical assessment, reflexes, cognitive, vision, perception, and then we partner with AAA and have the AAA vehicle with the trained professional in the driver's seat and the occupational therapist in the back seat to actually do a road test and kind of come up with a very comprehensive assessment that then you can have a discussion with your physician or for a loved one. Is this the right choice to keep driving with modifications, or really should you hang up the keys? But that's really such a unique and I think very valuable program that we certainly offer here at McLean. So with that, I'm going to pass it over to Peggy, and she's going to talk about home care and hospice.
So I'm the sweeper here. I hope you guys stay awake. I'm the last one in line. And I guess as I listen to my peers talk about their business lines and their specialties, I'm struck at, the true benefit of being part of a continuum. And, when Jenny says I oversee therapy for all the business lines, many of our staff work in inpatient, they might pick up shifts in outpatient, they might work in home care. So when you're part of the McLean continuum, the benefits are immense. The communication is there, we talk to each other, we know each other, and we work together. And I think the other thing that struck me during this talk was the continuum of Medicare. Because as we, at least at this table, all of our services are covered by Medicare. All of our services are directed by a physician. And these are requirements of the federal government, and your Medicare dollars are paid. So just as a little snippet to understand the goals of Medicare is always, appropriate to the topic tonight, which is to get the right amount of care in the right setting at the right time. So that's where you see if you, have a joint replaced and you end up going to our post-acute unit for for intensive rehab every day for 6 days after I've had 2 hips replaced, is not easy. I mean, you work hard, but the intent is to be able to get you home in a safer state. So Medicare would like, you're at the hospital, that's the acute level, they bring you down to the post-acute level, which is what Jenny was talking about, and then the goal is that you get home, but your care doesn't stop when you get home. It is incredibly important to keep the momentum going, and that's where home care comes into play. So some people are like, home care, is that where I get an aid? What is that? Home care is, it's a broader term, and most people in this room immediately know what a visiting nurse is. Everyone know what visiting nurse is? So home care is visiting nurse services. So, and we are considered a post-acute provider. So similar to all the services you would get in a rehab facility like McLean, you can access at home if your physician feels it's appropriate. So and the difference with home care is you don't have to be in a hospital first. You don't have to have been in a nursing home first. Your physician could make a direct referral for some VNA services. You go to the doctor for your regular checkup, you're looking a little shaky, he's concerned, I like to say he feels like you need a little tune-up. He could make a referral to VNA directly. And he's gonna say, I think I want a nurse out there, I want a physical therapist, and they really could probably use some help in the shower, so let's get an aide out there. So all of our services in visiting nurse are directed by your physician, and we report back to your physician on a very regular basis how you're doing, what we're doing, and he has to sign off and agree on the plan that the clinicians in home care have developed for you. And the other thing that sort of struck me about this lineup and this continuum is, we're talking at you, but you are what we do. And you're an essential part of any plan of care that any provider gives to you. So whenever I have an opportunity to talk to folks, I talk about being a good consumer. And that, so I compliment you all for coming tonight, because information is knowledge, and what you're getting tonight is a picture of the broad spectrum of services that McLean can offer you. And make sure you ask the questions. We had a chat with a lady earlier tonight, and she goes, when someone says your provider has to look at this, what does that mean exactly? Healthcare is very complicated, and we tend to use unique language to our business. So as an educated consumer, just say, I'm not sure I understand what you're saying, because we're fast and we're going fast. So I think the important takeaway on the continuum concept is McLean can be there for you to support you no matter where you are in your life. And engaging with us and being a part of this family and this continuum, you can enter and exit any one of these services as you need them. On the clinical side, we are geared to getting you stronger and healthier. And our success is when we can discharge you, when we can say, you're good. But then you always know you have us in your back pocket. Something changes, you pick up the phone, you call us, you're a part of us. So, I want to sort of really re-emphasize. Now, do we care for people who don't live on this campus? Absolutely. Do we care for people in other towns? We do. Our home care and hospice agency, there's a flyer over there that is a map, and it shows you all the towns that we service. We go to Granby's, we go to Canton, we go to Farmington, Bloomfield, Windsor. So our team in home care are considered a mobile workforce. So if they don't come into this building to see patients, we come to you. So frequently when I go out and talk in the community, I'll say, has anyone ever heard of McLean? I'll go to a senior center somewhere. And they're like, oh, that's a nursing home in Simsbury. And it's so much more than that. So we bring our services to you where you need it, and we're always hopeful that we're giving you the right amount of care at the right time in the right place. So please, the other huge benefit that we offer is our knowledge and expertise. We specialize in the older client. We don't take care of babies. We don't take care of anyone under 18. We specialize in the older client, and that means something. We're not training triathlon runners necessarily. We might care for them, but I want to emphasize the benefits of coming with an organization that identifies what they do. We do it well, and we take great pride in that. So if you were to get a referral from a physician or from a hospital or a nursing home that says you need VNA services, your physician will identify what you need, and you could have the full spectrum of services that you would have in the nursing home. We have nurses who come out if there's clinical issues, medical issues that you need some oversight on. We have physical therapists, we have occupational therapists, we have speech therapists, depending on what your needs are. We have home health, we call them home health aides in my world. They're CNA, they're all certified nursing assistants that can come out and help with those activities of daily living. We also offer medical social work services. And honestly, that's one of the ones that seems to be hardest to sell. People are always afraid, I don't want a social worker in my home. But the reality of social work in the VNA setting, in the home, is a resource coordinator. It is somebody who knows that program that you might benefit from, that loan closet, where is it? It might be, I think I need to apply for Medicaid. They won't help you apply, but they'll hook you up with resources because, once again, knowledge is power. So all of those sources, all of those services are available to you. It is Medicare will pay for this, both managed Medicare and traditional Medicare. It is considered a part-time intermittent service. So we come, we give a visit, we leave. They're usually 45 minutes to an hour long, and that's all depending on who we're working with. If you're really deconditioned, we're going to adjust what we're doing so that we certainly don't want to tire you out more. The other thing that VNA services can do for you is to help keep you out of the hospital. So one of the things that I'm very proud about with our VNA services is that we have an outstanding, it's called, in our language, probably doesn't mean anything to you guys, but it's called a rehospitalization rate. So sometimes, and it may have happened to some people in this room, where you went to the hospital, unforeseen, something happened, you got discharged, you went through all these levels of care, and then you took a turn for the worse. And you end up having to go back to the emergency department, you have to go back to the hospital. Nobody wants that. And we really pride ourselves on looking at the whole patient, patient-centered care, communicating with your physician, and keeping you out of the hospital. Having said that, we will be calling 911 if we walk into your home and we have concerns about you. So we're also a little bit of your safety net. I don't know if anyone in this room has been in a situation where they are like, oh, I don't feel quite right, I'm not sure, but I don't want to bother anybody, I don't want to bother my kids, I don't want to bother the doctor. You have a nurse come in, and they're going to look at you, and they're going to take some vitals, and they're going to say, it's time. And that can be very comforting. But so I'm talking kind of out of both sides of my mouth. One is that we're going to do our best to keep you out of the hospital, but two is that we are your safety net, and we will help you identify when what you're going through is not normal rehab, and that you probably need to go back. So you go through it, rinse and repeat, and then we come back out and we finish your service. So typically, people who get VNA services, it only lasts about 30 to 45 days. We're not out there for a long time. Because if we go back to what Medicare intentions are, is the right amount of care in the right setting. So what we may do, if you're not quite 100%, we're gonna refer you back to our outpatient therapy. Because you've come so far, maybe you can drive now, or maybe you can easily transfer in and out, but you still need some therapy. So we're gonna refer you to another McLean line that Jenny talked about. So, if you think about it, at this point in our lives, and I consider myself part of this cohort, it's a comfort to know that there are people who are experts in the care that is so confusing. I think Medicare, I think healthcare, I think it's very confusing. Is it managed? Is it not? Is it Part A? Is it Part B? We can help you navigate those items. Does anyone have questions about VNA services before I go on? I just said a lot.
I have a question, Peggy.
Sure.
Over here.
I saw you wave and I
Go ahead, go ahead. You have a question?
Oh, okay. So I thought I understood Jenny to say that they don't do occupational therapy outside of McLean. But because it's part of the home care services, that's why occupational and speech therapy are included?
You want to?
I can clarify. Sure. Hi there. So when you receive home care services, and I don't want to get too confusing, too in the weeds here, but as Peggy was saying, it's almost like a extension of that, a more of acute type of setting. So it's actually under a Part A benefit. Okay, so what that means is you're homebound. It's a difficult and taxing effort to get to the house. That's why Medicare reimburses those services in your home, because you can't go to an outpatient facility easily. You would be fatigued. You need the help of it's not just that you can't drive, but you need the help of a loved one. You need an assistive device. It's hard for you to get out. So with that being said, in home care, you have the full gamut of therapy services available: physical therapy, occupational therapy, speech therapy. When you're past that point, you're graduated, you're no longer homebound, which is our goal. We want to get you to the point of being able to go out socially, and that's the point. There's outpatient therapy if you haven't quite met your goals physically wise, mobility wise. For physical therapy, we not only offer those services to our campus residents, but to the community at large. However, unfortunately, we just don't have the staff, the occupational therapy staff in the outpatient setting to market that to the outside community. But as a campus resident, that is a service that we provide to you. Does that make sense?
Yes.
Sure.
Did you have a question here?
I do. So can you speak to home care services in AL? I think that's very
Yes.
confusing. I'll leave out hospice for now, because you haven't gone there yet. But AL services
Absolutely.
home care services in AL.
So, when you live in assisted living, that is your home. And so Medicare says that you can have VNA services where you live in your home in a residential setting. It's considered residential, it's not considered clinical. So frequently folks, not frequently, that sounds terrible, but occasionally, residents in AL, the great thing about AL is you've got a lot of eyes, assisted living, you've got a lot of eyes on you or on your loved one. And when they start to see a decline, you start, not being quite as vigorous as you were, or you have a new diagnosis, or maybe you bumped into your dresser and you cut your arm. the assisted living nurses will make a referral to our VNA, and we'll go out and see your loved one in assisted living for their VNA services, and those are covered by your Medicare benefit. So the only place that visiting nurse doesn't go in this continuum is in the nursing home, because you've got 24-hour nursing, you've got everything you need as part of your stay there. So we appreciate that opportunity, and what that does at the end of the day is keep you independent longer and enjoying in a higher quality of life. So a little something doesn't turn into a big crisis. So once again, always our goal is to have you not ever have to end up back in the nursing home. So we go out, we can give you physical therapy, occupational, we could even add an aid to it. You'll have aids in your assisted living, but maybe there's something special and you need extra care. So those services are always available in assisted living. Any other questions about home care? Sure.
I would just like to get something clarified. If your desire is to live at home until you pass away, then you are not going to be able to take advantage of the services that McLean has to offer because they have a cap of 30 to 45 days. Is that correct? Well,
So can I ask you to hold that thought until I tell my next part of my story?
Sure.
Okay. So under the Home Care and Hospice Agency here at McLean, which we consider sort of the hub of community-based services. So that means that we see you where you live. Another service line that we offer is hospice services. It is, it's a 5-star hospice agency. We're the only 5-star hospice agency in Connecticut. And just a very quick oversight of what is hospice. Oh, you're so good, Anne. So good. Keeping me on track. So hospice is specialized care for people who are nearing the end of their lives. So how do we know that? Well, we don't have crystal balls, and neither do doctors. But the way the Medicare benefits, when your doctor feels that if you were to die within the next 6 months, they would not be surprised. So we call it a life-limiting illness. Your doctor has to say, I think they're appropriate for hospice, and the Medicare benefit requires that a second doctor agrees with that decision. So it takes 2 doctors to say, I think that it's time. Now, if you are actively pursuing curative care, if you're getting chemo or radiation, or you want to do IVs, you would not be appropriate for hospice. So hospice is for folks who say, I think I've done enough. I don't want any more medical intervention. I want to focus on quality of life, not the length of life. So what happens in hospice is we provide you with this interdisciplinary team of people whose sole guide and whose sole mission is your comfort and your family's comfort, because the family is an incredibly part of any hospice journey. We support everyone. So we're not going to have you, if you say, I don't want to go for a walk, I don't care, it's fine. I want to have ice cream for breakfast, that's fine. Whatever you want. And a lot of the work that my clinicians and teams do is helping families come to grips with that. And this, as you can imagine, and I don't know if anyone in the room has ever been near someone or been participative in the hospice process, that can sometimes be the hardest part. And we certainly see people who keep fighting for their kids. I got it. So, sometimes we can really help with family relationships. And quite frankly, hospice does its best work with time. So people believe, a little misnomer out there is that, oh, you've given up on me, I'm gonna die next week. A, no one's given up on you, but B, we really wanna see you before you die next week. The benefit comes in 6-month periods. So what we can do is, your hospice team includes a nurse, it includes a social worker, it includes our hospice medical director or your primary care doctor. We have home health aides. We have chaplain services, and chaplain is a very broad term. The new phrase is really spiritual care. To just, if there's some existential stuff or there's something that you need. The team kind of surrounds you in this hug, and and honestly, if you think about the continuum of healthcare, this is the one part of your healthcare that you actually are in charge of. You get to decide. It's not that the doctor says yes or no, or the nurse says you're not doing this, or you have to. You are it. This is your time to shine. And so, as much as you want or as little as you want, and we take our cue from you. And we also have an incredibly robust volunteer program. And this is a Medicare requirement. If you have a hospice, you have to have a volunteer program. You have to have X number of hours. And I will tell you that staff that I have hired, I've been here at McLean for 8 years. When I hire new staff, they will say, and who come from other hospices, I have never seen such a robust volunteer program. So you're sitting there thinking, what am I going to use a volunteer for? They're not going to sign letters. Those are kind of our foot soldiers. They can help make your wishes come true. Would you like pet therapy? Would you want to have someone to visit you and have that dog sit on the end of your bed? Do you want music therapy? Do you want, a lot of people do life reflection. We can document things. So they really are the ones who fulfill so many of the wishes. But you are under the care of a physician, and but it's a 24-hour a day, 7 days a week. The other misnomer that some people have about hospice is they believe someone will move in with them. And that is not what the benefit is. It is, once again, intermittent. The team goes out, visits, they leave. So what we do is help you figure out, are there gaps you need to fill? Do you need some private aid time? You're not able to we have aides, but it's an intermittent aid. If you need someone to stay with you overnight, our social workers can help you find those services. So the program is designed really, and hospice is actually the one business line here tonight that can serve you in any one of these places. We see patients in nursing homes, we see patients in assisted living, and we see patients in the community in their home. So what we try to do is figure out what your wishes are and what you want. And I always say there's some crazy statistic about 70% of Americans say I want to die at home. But the reality is that only about 30% of us actually can. And I believe part of that is because we don't consider hospice early enough so that we can set it up for you. But, and I also say to people, it doesn't mean if you end up having to go into a nursing home, you can make that nursing home your home. You can bring your favorite chair, your quilt, your music, your pictures. You can have the pets visit you. So, some of the things that I've heard that hold people back from considering this, but it is a benefit and a service that you have paid into all of your life because it's a Medicare benefit. And it sits there and it's waiting for you. And too many people don't access it. So, okay. Questions about hospice? I'm going to stop talking. Yeah.
I believe that once someone transitions to hospice, Medicare pays for all the medications.
Yes, so hospice is somewhat of an all-inclusive thing. So let's say you have 6 different pills that you're taking, but the reason that you're coming on hospice is for, a respiratory problem. That's considered your terminal illness. The hospice will pay for the medicines that will give you comfort for that disease process. But if you are on a cholesterol drug, honestly, one of the things that we like to do is get rid of drugs that you don't really need because you're nearing the end of your life. But if you say, no, I want to stay on my cholesterol drug, I want it, you would pay for that through your Part D benefit, just like you do now. So anything that is attached to the reason why you are in hospice is included in the hospice benefit. It does not pay for room and board. So if you do end up in the nursing home, that would either be, if you are on Medicaid, would pay for room and board, or it would be a private pay bill.
I'm gonna give you a nice plug, being that we went through hospice here with my mother-in-law. It was the most fantastic thing. They took care, not only my mother-in-law, keeping her calm, but, you know, they would feed us when we were all there, and it was just fantastic. Yeah,
Thank you. I appreciate the plug, but I'm glad that your experience was a positive
it
one.
was definitely a positive.
And it extended beyond just her passing. It extended into the year,
Yep.
year following.
Yeah.
Great point. Part of your hospice benefit is a bereavement aspect, which means that we follow you, we connect with you, we send you newsletters, information for 11 months after the death of your loved one.
Fantastic.
And then we are always there. We offer bereavement support groups. We're always there. You know, grief is not a straight line. It's one of these things. And it could be 3 months later and it hits you. Pick up the phone and you call us. Somebody else? Hi.
Hi, I just wanted to ask, does McLean Hospice, do they contract with other nursing homes? Because I know, sometimes you can request, to have McLean Hospice, but maybe that nursing home does not contract with you. Is that how that works?
Well, so that's another great Medicare question. It's complicated. So we, as a hospice, we have contracts with the area nursing homes, with almost all of them. Avon Healthcare, Cherrybrook, all the way down to Avery Heights. That means that we have agreed that if they have identified a patient who will benefit from hospice services, that it's sort of like, we agree we'll do this and you do that. But there are nursing homes we don't have contracts with, but Medicare is very clear that patient choice is ultimate. So if you end up, or your loved one is in a nursing home that doesn't necessarily have a contract with us, that facility needs to reach out and we can do what we call, language again, a one-time only. And so I want to reinforce to everybody, knowledge is power, choice is your right. So you can always choose your provider. And the thing about hospice is when you elect that benefit, even if you have an Aetna or a managed Medicare, before you go on hospice, you'll convert to traditional Medicare and you'll have all the protections of the federal government in that program.
Is that true if the patient is also on Medicaid?
Yep. It's called language, dually eligible, so you may have Medicaid and Medicare.
Thank you.
Great. Okay, so I've been talking more than everybody else combined. There's one more program that I want to talk about that lives in the home care world, and that is our care consultant that Ann alluded to, that Michaela alluded to. And Amy, you want to stand up? Ta-da! Amy is a care consultant. Anyone ever heard of that before? Anyone know what that is? Used to be called geriatric care manager, care coordinator. Basically, this is a service. It is a private pay service. Insurance does not reimburse for this service. But just as you've heard tonight how complicated everything is, do I do outpatient? Do I do Part B? Do I do A? I need some help. I don't need a lot, but I don't think, all of those things. And frequently issues come up at a crisis time, like you've had a change or your loved one has. You can hire Amy to, our friend Carlene always likens it to, what do you say, Carlene? Adopt a daughter. She can stand in, she can make the phone calls, she can arrange the care. She can have honest conversations about what's going on with you and review what your options are. And this is a newer program that we've had, and right now we only offer it to residents on our campus, and Amy services anyone in independent living or assisted living if they should need it. But the really exciting news, hot off the press, is in October, we're going to start offering the service out into the greater Farmington Valley where we serve our home care patients. So I can't emphasize enough, unless you've been in the muck and mire of trying to navigate things, you might not appreciate why would you hire someone to make a phone call? Well, because there's about 85 different private duty agencies, there's a Part B at Home program, there's Meals on Wheels, there's resources. You know, at the end of the day, I don't think anyone says, gosh, I wish I hadn't spent that money to figure this out. The other thing, you know, she can do as much or as little as you want. It is, if you say, I think this is what I need, I'll do it all myself, just tell me what to do. She'll give you resources that you can call, but she can do the part that people, I think, get a little hung up on, what I think is the huge benefit of care consulting, is she can do the dirty work. You know, when you are trying to connect two human beings together, like you're gonna get an aide in your home 3 times a week to help you shower and do homemaking, and they don't quite work out. They're not really, you're not making a connection. You know, this is very intimate service that people provide, but not everyone was made to be together, right? Amy can be the one who can help you navigate that. You know, she'll check in. How is it going? Are they showing up? Are they showing up on time? Do you feel comfortable? Do you feel safe? And if they're not, you just call Amy and say, I think I need somebody else. This isn't working. She makes the phone call. You know, and I'm kind of like that. Like, I don't want to tell someone, I'm not feeling this. It's hard to say that to somebody. That's what Amy can do for you. She can make those hard phone calls. And if you've got a plan and you're set up, Amy takes a step back. But once again, she's that tool in your back pocket, because nothing stays the same but change, and something might come up. Pick up the phone and say, oh, Amy, help. She'll be right there, and she'll go see you, and she will help you figure out what the next steps are. Any questions about care consulting? Yeah. So, I think that wraps it up.
I have another question.
Oh, sure.
If somebody moves in here and opts for the life care plan,
Mhm.
all of this is included?
Well, we are, the way the life plan, you're part of the continuum, but you are accessing your Medicare benefits to pay for these services. So this is not like part of your rent necessarily, but you have priority position for any of these services. So, yeah, all right, I'm gonna shut up now. Trouble.
No, you were right, but just to clarify further, if you were to need assisted living or long-term care, that is an additional out-of-pocket expense. It is not included with your life plan fees. So it is additional unless you have like a long-term care insurance for long-term care, and obviously if it's a post-acute stay, insurance will cover that. But assisted living or long-term care, if you do have the funds, is out of pocket.
And then therapy is usually covered underneath insurance. You know, sometimes there's just a select few that we don't participate with, but it's always, you know, I think, as Michaela said, if you have a managed Medicare, we get authorization. So same thing in regards to outpatient therapy. If you do get a referral from the doctor, just give us a call, let us know your insurance, and we authorize that and make sure we're participating, and we can let you know if there is or is not a copay, and all that up front so that you know going into it.
And I will say,
I'm gonna ask a hard question. So what is the benefit of moving in?
Well, I mean, me personally, first of all, of course, the facilities, right? We have beautiful facilities, independent living, everything else. We have a beautiful view, right? We have nature, we have the game refuge, all of that access. But again, we are a 5-star facility. Peggy said with hospice, our SNF is a 5-star facility. We pride ourselves on the care, the services, the life enrichment activities, the hobbies that we have, but also the health care, right? That's where our heart and our bread and butter is and what we're good at. So like any place, there's not a life plan community out there, I don't think that's all encompassing. They would always access your insurance, right? It's somebody's choice. Are they gonna go on traditional Medicare? Are they gonna go for a managed? And that might determine the pathway of how much out of pocket you have to pay. But again, the plus of being here, aside from all the beautiful amenities and the activities, is that priority access. Because we do have limited beds, and you know, we do have a long wait list already for long-term care. But by being a campus resident, we can tell you that we make sure that, you know, we meet you where you are.
I like to say the biggest benefit is peace of mind, knowing that you will be cared for throughout whatever may happen.
Right.
You know, the goal is maybe you're in independent living with hospice, which is an option. Or if you need assisted living or the nursing home, you have that at your fingertips and you're not frantically searching for the care you need in a crisis. It's taken care of, and I think that's the biggest benefit.
Well, that was a good answer, thank you.
Can I just say something?
Sure.
You know, I've worked in senior healthcare for really all of my career, and I think the other benefit is, A, we know what we do well and we pride ourselves in that, but we are not a huge organization. You know, you call up home care, you're gonna get Renee or you're gonna get Donna. If you're a hospice patient, our medical director is gonna know your name. That is the personalized level of care that when you are in this continuum, if you were, you know, if you were in outpatient therapy and your doctor made a referral to VNA services, we pick up the phone and we call Joan an outpatient. It's like, what's going on? Have you discharged? So it's that connection, it's sort of the silver thread that ties all the pieces together for you that really helps with that navigating. And I've worked in a lot of different settings, and I think that to me is worth its weight in gold.
I have a question for Michaela. So Michaela, whether you're a member of our continuum on this campus or you're not, how does someone who's in the hospital, who's had maybe a fall and looking for post-acute, how do they get to you?
So, your first step with post-acute care is most hospitals will assign you and your family a case manager. The case managers will come in and say, okay, the physical therapy or the medical doctor has said, you know, we're recommending therapy. They're gonna want you to give 3 or 4 names of facilities. Now, if you live here on campus, you just need to say, I live at McLean, make a referral there. If you don't, they're gonna want 3 or 4 different options due to bed availability. You know, we're only a 14-bed unit. We do tend to stay pretty full. I try my best. And they'll, from there, make those referrals, and the facilities will review your medical records and make sure you can, you know, your needs can be met. We don't want to admit anybody that we can't care for, so there is a very in-depth medical review of each patient before they come into post-acute care. And then you can always take my card and call me directly from the hospital. I have received calls from people in the hospital saying, I just got out of surgery and I need a bed, are you able to help me? And we certainly will try our best. But again, on the same note of post-acute, and when I mentioned earlier about putting in wait lists for long-term care, I say it's worth to go pop into a couple different places in the area, get a feel, because in that moment, you don't want to be scrambling and thinking, oh gosh, it's, you know, I just like McLean, or I just like Cherryburg, or I just like Seabury. You want to make sure that you've seen a couple places, you kind of get a feel for the care there, a feel for the facilities. That way you can make a more informed choice, because they'll come back and say, okay, out of your 4 choices, only 2 of them offered a bed. So then you're going to be going in between, and you know, having that knowledge of what the facilities are like will really help you make that decision.
Do we have other questions from the floor?
Is it possible to see the long-term care facility or?
Of course.
I've seen rehab, because my mother was there, but.
All you would have to do is give me a call, my card is over there, and I would love to take anybody on a tour, just to take a look so you guys can get a feel of long-term care and our staff, the room setups, everything. I'm more than happy to show anybody around, whatever you'd like.
Other questions?
No, I'm just gonna speak to the value of priority access. Before we moved here, through the hospital, we needed a full week of residential rehab. Hospital says by far the best is McLean. but we're not sure we can get you in. They're almost always full. Because we were residents, a bed appeared.
It's magic.
I mean, that.
Funny how that happens sometimes, right?
Well, it was worth a lot to us, because to have me scrambling for something when I'm already worried to get the call, oh, well, you're a McLean resident. Yes, we have a bed for you. That was worth a lot.
Thank you for that plug again. Other questions?
If you're not a resident, what is the waiting list? Is it, just give up because it doesn't sound like you're gonna get in here if you really need to? As far as long-term care, I mean, if you're planning on staying home as long as possible, and then you need, more care, what is the wait list? What are you talking about?
Loaded question. So the wait, because, let me backpedal. Because we're a continuum here, as we've been talking about, and the priority access, our wait list tends to be a little bit long because we're filling our long-term from within a lot of the time. Sometimes if there's open beds, we do call down the wait list. Sometimes people will admit through post-acute if they're unable to go home. Again, right now, our wait list is at about 185 people.
Ready?
44.
That's more than I probably have.
Yep, so again, the sooner you can put your name in on the wait list, the better, because obviously everyone's goal is to stay home as long as possible. So even if that's 5 years down the road, 10 years down the road, the likelihood of your name being higher on the list is much better.
Can you speak to how does the wait list work? Like some people have asked me if they pass, if you call them.
Sure, so Connecticut actually has really strict wait list laws, so I have to be very careful with how we operate. So when a bed opens up, you have to call every person on the list in order, regardless of their payer source, to see if they're ready to move in. If they're not ready to move in, you stay where you are on the list, you don't drop to the bottom. So if I call you and you're number 45 and you say, no, I'm not ready, you'll stay number 45. You won't drop down to the bottom of the list. So that's a benefit too. You can always pass that up.
Other questions?
I don't have a question, I just wanted to make a comment with regard to getting care for rehab. I had to go to rehab unexpectedly, and when I got discharged from the hospital, I was told that there was a list and to pick some place. And so I said, well, I'd really like to go to McLean, and they said, that's probably not gonna happen, so pick something else. Anyway, I picked a few other places, and nobody had a bed except this one rehab center, which is close to here, but I'm not gonna tell you. It's a god-awful place ever. And I know it had a bad reputation, and I didn't wanna go there. So I said, well, what happens if I say no? And they said, well, it's gonna cost you probably $8,000 or $9,000 a day
To stay in the
here
hospital.
Because Medicaid, you have met all of the requirements for being discharged. So if you walk and say you're not gonna leave, you can pick up the tab yourself. Well, understandably, I said, okay. And it was awful. And I was there for 2 weeks, and it was probably the worst experience in my life. So I just wanted to tell you that those places do exist. I was convinced when I got out of there that I was gonna call the state of Connecticut and let them know just how awful that place was. But the visiting nurses told me that most places are like that, which was very discouraging.
Yeah.
So
Let me-
Yeah, I'm so sorry that you had that awful experience.
Can I just touch on something you said when the hospital said, basically, we're not even gonna try to get you into McLean? Don't let them tell you that. You will say, reach out to me directly. Families have said, they want a referral to McLean, and because we do tend to be full, sometimes the hospitals, for efficiency's sake, will say, they're typically full, we're not gonna send a referral. It is your right to have them send a referral to whatever facility you want. And if for some reason they're saying McLean doesn't have a bed, feel free to call me directly and confirm that. That might be the case, or they might have just assumed that we were full. So.
Well, thank you for, yes, actually, my husband did call,
No.
and he tried to get me in here, but you were full, so.
I'm sorry about that.
Other questions?
Mine isn't really a question, it's just a flattering comment to Michaela of how wonderful she is, because I was told that my mom, a few years ago, could no longer stay where she was, and she needed to go to a nursing home, and if her care deteriorated, or if her ADL status deteriorated anymore, that she was gonna be forced to go to a nursing home, so that I would need to make sure she was on a certain wait list. So I talked to my mom, I made the application so she was on a wait list. And I said to Michaela, as we were talking about it, I said, she called me and she said, your mom's application has been approved and she's on the wait list, and she was number 248. And this was about 4 years ago. And I was like, 248, what the, how is that even gonna happen? And she said, well, don't worry about it. If something were to happen to your mom and she ends up going to the hospital, just call me. Tell, like this, you call 911 and then you call me. And it's exactly what I did. I mean, she was very honest, and that was exactly what I did. So I knew the ambulance was coming. They knew that she was going to the hospital. She fell and broke her arm, her wrist. And so that was all in motion, but at the same time, Michaela knew she was going to the hospital. She knew she was going to need post-acute care, and she knew that she was already on the wait list for a skilled nursing bed. So I said, well, what the heck are we even going to do? And she's like, don't worry about it. And I really, everybody here said to me, don't worry about it. Anytime I had a question, I mean, they answered my questions, but every answer was always followed by, you know, don't worry about it. We are going to take good care of her. We're going to do the next right thing, and she's going to be fine. And she was. You guys did a great job.
Thank you so much. That means so much to me.
Head of the wait list somehow.
Yeah.
You know, and I'd like to say, here at McLean, we are not perfect, but we really do try to be better tomorrow than we are today, all the time, and as example of these great people on our panel here. And I think it's also worth noting that, and I think Peggy alluded to it, that we are a 5-star hospice home care program, the only one in the state. We are a 5-star skilled nursing facility, and we have been voted best assisted living for 2 years in a row here at McLean. So a lot of work goes into that, and again, we have very dedicated people, really good people here working for the right reasons every day. So we're very proud of that. Other questions?
I can't remember the context where it came up, the driving assessment. You know, I like being proactive, but perhaps I like to drive, but I know I'm slowing down a little bit, or maybe I think I can't drive at night, but under what circumstances is someone here going to tell me that I'm disqualified?
Right, so again, so the trained OT in that driving assessment is gonna do a comprehensive evaluation, and then again, we partner with AAA, get on the road and actually do a road test as well. They come together, both of them discuss, and we present our findings, objective clinical findings.
But who tells me I want this assessment?
Oh, that can come from your physician, like the physician, you might be having that conversation with your physician. We always want a physician referral, but the other big thing is family, right? You know, family might recognize like, oh, you know, and it's always hard to have those conversations, right? And no one wants to give up their independence in driving. That's such a touchy subject. The person that's driving, but we also don't want to injure ourselves or injure other people either, right? So it really helps to put an objective finding to something, have that discussion, and again, we as therapists can't take your license away or anything like that. We present to you what we're finding, have that discussion, recommendations, Because we need a physician's referral to do this, even though it is private pay, we send those findings to your doctor to then have that conversation with your doctor. And again, it might be you passed, it might be, you know what, you're doing great, but yeah, stick to the daytime. Nighttime is probably gonna be a little bit of an issue because of vision or what have you. So there's all sorts of recommendations that we may make, but ultimately then that decision comes from you and your doctor.
Other questions?
Can you talk a little bit more about independent living here? I noticed you have, I've never been here before, you have like a village over here and a village over there. Whatever.
Sure. So if we start chronologically, that we have, as you came in, the brick buildings to my left now, those are, consider those the cottages, so that's independent living. Behind them, if you pass that, clapboard buildings are independent living again, are villas. To my right is the Burkholder, which is an older building than this building, which is 3 years old. So the Burkholder, again, apartment building. This is the Goodrich, and was opened 3 years ago, again, independent living. So these are all independent living buildings.
How many independent units do you have?
I think we have 13 cottages and villas.
116.
116, there we go.
The experts are in the back of the room.
116 independent living apartments.
103 apartments.
103 apartments.
13 villas.
13 villas. Does that answer your question, or were you looking for more in depth?
Can I ask you another question?
Sure.
I looked at your website and I was confused. It talked about a refund policy of the fee, so I didn't understand that whole thing.
Jameson?
Yeah, I would say that's a totally different subject, and we would love for you to call us, and I can explain all of that to you one-on-one. I don't want to confuse everybody tonight, but I'll give you my card on the way out.
And we can always do, in your surveys, fill out what you want us to do for a topic, and we can do one on independent living specifically, or like Kate had said, come see us. We want to be a resource. But there's a lot to cover in that. That's a whole night itself.
Other questions tonight? As Jameson said, please take time to fill out your survey. That helps us moving forward. I just want to thank everybody here tonight on the panel for taking their time, and thank you all for coming out this evening.